retainers. I know we have doctors, we have hygienist assistants, and also some front staff. So we're going to go over the different types of retainers. We're also going to go over the challenges to maintaining a stable occlusion. And then we're going to review some concepts on neutralizing these challenges and then determine an overall protocol that should be consistent. So for retainers, there's removable retainers and there's bonded retainers. Okay, so removable retainers, obviously you take them in and out. They're called a conventional, a Hawley, a circumferential. There's basically wire and acrylic. There's also a True Tape, Essex, VFR. They're the clear ones that kind of look like Invisalign. We have positioners that are also used. They're usually used if you have some minor tweaking you want to do or you want to stabilize a bite. And then we have mouth guards or night guards. For bonded retainers, we have wires that are either braided or solid. And then we have appliances like maxillary holding arches. So when we talk about retainers, there's a ton of different stuff that we're talking about. So this is your conventional wire and acrylic retainer. They can be designed all different ways. It just depends on the doctor and the lab that's making them. This is a circumferential that has a wire that goes all the way around. We've got ones that replace teeth, Pontics retainers, spring retainers, and then just your conventional retainer. The pros to that is they're durable. It allows for some settling of the back teeth. You can add teeth, you can add a bite plane. I think the biggest cons to it are that they don't encapsulate the teeth right after the braces come off. They're expensive to have made by a lab. They can sometimes, if there's any adjustments that were done, the fit might be not perfect. They're not very aesthetic. Patients have speech issues and it requires lab time to have them fabricated. For the True Tainer Essex retainer, the vacuum formed retainers, these ones are used primarily because they're aesthetic. So kids will actually wear them. So when a teenager gets their braces off, they're going to want to wear this clear thing. It looks like Invisalign. You can't really see that they're wearing it. It has intimate contact with the teeth. There's very little speech issues. It's easy to make. You can make it in your office. You don't have to send it to a lab, and therefore it's very low cost. The biggest drawbacks are it's not durable. Okay, so if they clench or grind their teeth, they may actually wear through these very quickly. You can also put a tooth in this one too, so it's really nice if somebody has a broken Pontic retainer or flipper, they can pop a little tooth into their True Tainer. We also have positioners, and back in the day they used to make these positioners like this. It would be to allow someone to bite and settle their bite a little bit better. I don't have a huge history with positioners, but recently there's this thing called the Damon retention splint, and when you start your Damon treatment philosophy kind of learning, they tell you need to have one of these for every one of your patients, and they really push it. It's basically a vacuum form upper and lower that's together, so that it holds the teeth where they are long term. It's designed to maintain the muscular balance following Damon treatment in order to prevent relapse. We're going to discuss this. This came right off of their website. We're going to discuss this later. There's also night guards, and of course we use those for clenching or grinding. Any questions about removable retainers? No? So bonded retainers can either be braided wires. We currently use a braided gold wire that's bonded to each tooth. You can also have a solid wire that maybe is just bonded to the teeth, the canine teeth on either side. These are great because they're aesthetic. There's no speech issues. They're utterly forgettable. So patients put them in and they forget they're wearing them. They forget to take care of them. They forget to clean them. How many of my hygienists love patients that have bonded retainers? Anyone? How many of my hygienists hate bonded retainers? How about my dentists? Hate them, right? And you leave them on forever? We're going to get to just stifle. So another kind of retainer is a bonded retainer that's an appliance. Also keeps those anterior teeth where they are. It'll keep arch length and it'll keep any kind of expansion if we did expansion and the patient could tolerate the expander for very long. It is a lab fabricated appliance and it can loosen up if kids forget that they have it in there. They eat popcorn, there's kernels in there and drama ensues. So I'm going to have you guys tell me a little bit about yourselves right now. How many of you guys out there had braces? How many of you received retainers at the end of braces? And how many of you currently wear your retainers following your orthodontist? Keep your hands up. I got treats for you guys. Anyone over here?
Good night. I'm not going to say every day. I'm not going to have 3 times.
Well, that's organized. Orthodontic patients.
Second time, like 5
So somebody that got a treat. Somebody that, you in the purple in the back. You wear your retainer. Okay. How long have you been out of braces? Okay. And do you wear your retainer exactly the way they told you when you were 14? You just wear it at night. And is that because you're kind of in the dental field and you know people looking at your teeth? Well, kind of begs the question, what happens with patients who have to wear retainers, right? Most of our patients, or the vast majority of them, are young. They're either real little kids, 8, 9, 10, or teenagers that are getting out of braces. So there was a study done in 2011, it was published, and it was over 1,000 orthodontic patients that were between 6 months and 6 years out of treatment. Patients were more compliant with their True-Tain or Essex removable retainer in the first 2 years after debonding their braces. So if they were given one of those clear retainers, they wore it. Okay? After 2 years, they stopped wearing it. Patients who received Hawley retainers were not as compliant in the beginning, but they were compliant long term. Okay? So this becomes, kind of, then it turns around to the orthodontist. Well, what are you going to do? If you know that a Hawley patient won't wear it maybe in the beginning, but they're going to wear it longer, what do you do? So they did a study of, they continued following this up, and they found that there were some gender issues, age issues, and patient understanding factors that came into compliance. So with gender, they found out, and ladies, women are better wearing their retainers than the boys were, okay? They also found that very young patients, so the very little 7, 8, 9-year-olds, were more compliant with wearing their retainers than the teenagers. They also found that adult patients were much more compliant with their retainers than the teenagers. So again, it comes down to, we've got all these teenagers that are going to get done with braces. What happens? What are we going to do for their retention? So they started to ask these similar questions to the orthodontists. And it was interesting because they interviewed 9,000 orthodontists. And this survey showed that the predominant use of for the upper retainer was a removable. It was equal between the True-Tain and the Hawley retainers. But it was always a removable retainer for the top. For the bottom, it was predominantly a fixed retainer. Okay, so a bonded one that was on the lower 3-3 or K9 to K9. Orthodontists who reported lower extraction rates recommended fixed retainers. Orthodontists who reported lower extraction rates also recommended lifetime retention. Okay, and these studies are kind of, they were looking at what's going on now, currently, versus what had been going on back in the 80s and 90s. They basically said at the end of the day, orthodontists grossly overestimate our patient compliance. That makes me feel bad. So, if we know our teenagers aren't going to wear it, maybe our boys are not going to be as good as our girls, and that I'm overestimating they're actually wearing their retainers, So what am I going to do? Is there a way that I can reduce or even eliminate retainers at the end of treatment? Well, I'm going to go back to where I was when I finished school. So I was a pretty good student, I think. I did well in school. I took the first part of my board exams in 1999. We did a lot of retention studies in order to take the board exam. And these were the number one things that we knew about long-term post-treatment stability back in 1999. First was that increases in the dental arch length, so from molar to molar, and width during orthodontic treatment, we increase that, it will tend to return to pre-treatment values after retainers are discontinued. Expanding the intercanine distance will constrict after retention is finished. Lower arch form tends to return toward its pre-treatment shape after retainers are done. Advancing the lower incisors is generally unstable. It's basically pushing these incisors out from over stable bone to unstable bone. The arch length decreases from the mixed dentition through the adult dentition and continues throughout life. Okay? So all of this is showing us that when we do treatment, all of these things that are happening, we have these situations that we know are going to be unstable. Pushing the molars forward, increasing the canine width, changing arch form. But that's not it. There's a ton of things that cause relapse. Growth, connective tissue fibers, shaped incisors, periodontal disease, third molars, habits, condylar remodeling. With all of these variables that will result in relapse, how do we create stability? And I'll have to tell you, this was really frustrating to me because I took my second part of the board exam about 5 or 6 years later, and I felt like I was hitting myself in the head. I'd gone to school for 23 years. I was doing this great profession that I loved, and nothing is stable. It's so frustrating. So I went back to the literature again. And this was about the time that a bunch of studies were coming out of the University of Washington at Seattle. These are the kind of gold standard for retention studies. Whenever anybody talks to you about retention nowadays, it's all based on these studies. Again, it came out with some bad news, came out with some good news, and it came out with some really, really, really bad news. So the bad news is basically what we knew before. Lower incisor crowding increases post-treatment regardless of the length of the retention. So it doesn't matter if they wear a retainer for 6 months or 5 years. If they don't wear a retainer, their teeth go back to lower incisor crowding. The arch length and the arch width decreases with time. Okay, so we know that if we expand the arch width or the intercanine distance, then it's going to decrease. That's okay. And then axial inclination, so tipping the teeth or kind of treating the patient to the profile cephalometric x-ray, treating to those norms or the normal values, it doesn't produce stability. These studies showed there were no predictors for post-treatment stability. Kind of a big bummer. The good news, sort of, was that all of this was evidence-based. It wasn't a philosophy, it wasn't, I think, or I believe, or I see this. It's evidence-based. And it basically says orthodontists and non-orthodontists, or dentists doing ortho, are not to blame for the relapse. It's just going to happen. It's just going to happen. The bottom line is long-term retention isn't our feature. That retention and stability is the patient's responsibility. We need to retain until their growth is complete. When is that? Because I still keep getting older, and I still am growing. Usually this way, for sure. Lead this way too. So when is that? Is it at 25? Is it 55? When do you stop growing? So it kind of put the bottom line to all these studies where the patients are stuck. You do braces, you're stuck with a retainer for the rest of your life. I don't like it. I hate it. That stinks. Do whatever you want. You can move the teeth anywhere you want. Just make sure they wear a permanent retainer. Let's get back to that. How many of you guys really like to see your patients in permanent retainers? Nobody. Why? Because the hygiene issues. Because patients forget to floss it. Because really at the end of the day, are we just holding these teeth there because we know as soon as we take the retainer off, it's going to collapse? That's not good. I don't like that. So it became really easy, and a lot of orthodontists became brain dead. It didn't matter what the diagnosis was, as long as we used bonded retainers. Hey, we can use these preformed arch wires. And look at it. Those preformed arch wires are getting bigger and bigger and bigger. Because you know what? If you use these big, wide arch wires, maybe you don't have to extract. Oh, and then don't forget the magic braces. You put the magic braces and the magic wires, and you don't have to see your patients every 4 to 6 weeks. Wow! Everything works, but nothing matters. So again, is long-term stability without retention possible? Well, what happens with no retention right after you take the braces off? If I take the braces off my patients and don't put retainers on, what can happen? And they did a study and they showed again, lower incisors relapse within 4 to 12 weeks. So if you tip those teeth forward, they're going to relapse in 1 to 3 months. Expanding that intercanine width on the lower, you're going to relapse again, 1 to 3 months. Changing the lower arch form, 3 to 12 months. Rotations, they'll relapse within 4 to 8 weeks. Tipping of bodily displaced teeth, so teeth that maybe come in the palate or lingual, they're going to relapse in 2 to 4 weeks. That stinks. Why do you work for 2 years to have all this unravel in a couple of months? They basically found that there are 9 local relapse factors. There are 9 significant areas that if we address those, that our local relapse, our relapse right after we take braces off, are reduced. Okay? So it's patients that have displaced connective tissue. So these two central incisors are facing each other. We rotate them around 90 degrees. They're going to want to go back to this position. Expansion of the intercanine width, we've already talked about that. If we expand it, we have to do these bonded retainers. Teeth that are severely crowded and rotated, they need to have overcorrection, otherwise they will come back. Advancing lower incisors. This was a patient who was told, you don't need to have teeth extracted, we'll put on these magic braces and everything's going to look fine. And if you look at it, she's still class 1. But look at where these teeth are. They're way, way out there. She's going to walk around the corner, you're going to see her teeth before you see her. We have unfavorably shaped lower incisors. These will, for sure, lead to crowding later on. And then changing the lower arch form. Again, I told you guys about the arch forms over the last 10 years have just been getting broader and broader and broader. Bodily displaced teeth, this tooth that's way in here, we move that forward, take the braces off and don't retain, it's going to go right back here. Tongue and thumb habits and forces of occlusion. These are the 9 top areas that we need to address during treatment to reduce our requirements for retention post-treatment. So these are the things that I do, and this is what I recommend to my patients. When we have displaced connective tissue or severe rotations, I highly recommend a fibrotomy, supracrestal fibrotomy. Okay? Does everybody know what that is? Is anybody unaware of what that is? Okay. Okay. So a fibrotomy is where you go right above the crest, so in the sulcus, and you cut the elastic fibers using a scalpel. I think they might even be using lasers for that, doctors.
Definitely.
But basically what happens is you're taking these teeth that have really rotated and they have all these elastic fibers that want to pull them back, and you're cutting them so they don't have that pull. Okay? So I recommend the fibrotomy. Oh, yes?
Do you do it?
I am not doing fibrotomies right now. I don't do them.
Or do you use
just to have it done. I have putting this into my arsenal, but I don't, because what's happening is that I'm recommending this fibrotomy, and the parents don't want to pay extra money. It's not covered by insurance. You know, oh, it's extreme, what have you. But this is definitely, when we have really crowded teeth, this is really important to do. When we, the expansion of the intercanine width, ideally, we don't do it. If we do it, and we have to inform the patient that we're doing it, and they're going to have a permanent retainer, and what the risks are associated with that. Okay? Ideally, we want to maintain that width. If there's, if we lack overcorrection or we need it, we want to overcorrect on all cases, whether that be with the bite correction or the rotations of teeth. If the lower incisors are being advanced, not good. We want to avoid it, essentially. And really the only way to avoid that lower incisor tipping forward is the one thing nobody wants to hear, extraction. There are times that extractions are necessary. I was just at a conference in May, and a couple of the speakers got up, and the second speaker said, I missed the beginning of it, the second speaker came in and he said, I'm just like him, 85% of my patients are extraction patients. And he showed these cases that were beautiful, faces, beautiful, none of those sunken in profiles, really, really great cases, never wore a retainer. 30, 40 years out of treatment, never wore a retainer because he extracted the right way on the right patients. But he has a high extraction rate. I'm probably maybe 20% of my patients, 15 to 20% are extraction patients. Unfavorably shaped lower incisors require interproximal reduction. That's going to increase their stability. If the lower arch form looks like it's going to be changed, we want to avoid it. And if we do need to change it, we want to use custom arch wires so that it matches them. We're not using these big, fat, broad ones. We use customized arch wires for that patient. For bodily displaced teeth, we want to use selective root torque. So having a bracket that you can actually engage fully with the wire and use little torquing keys that we have to move those teeth and move the roots where they're supposed to be and even overcorrected. For tongue and thumb habits, I want to overcorrect those or I refer them out. And then forces of occlusion, I want to equilibrate marginal ridges where if the patient has a ton of anterior, really old, thick crowns, I request that they get them replaced. So, I hope that makes you guys happy. But all of that said, we're talking about right afterwards, right after the braces come off, we see this immediate relapse. Well, what happens 10 years down the road? What if we took care of all those little 9 little issues with the IPR and if they needed extractions, they needed a fibrotomy, what happens then? Well, it turns out there's 2 types of relapse. There's the initial relapse, that look at those 9 factors that happen right after braces come off. And there's physiologic relapse. This is found in all patients, whether you've had braces or you've never had braces. It is slow-paced, age-related changes to the dentition. Lower incisors crowd, we have decreased intercanine width, and we have a reduction in overall arch length. Okay? Again, if we get to this point and they're 20 years out of braces and we're starting to see some little changes, really our best way to take care of all of these 3 things is with just a very minimal IPR. Just go right in there really lightly and do some IPR and those teeth will go back to, you can put a little spring retainer on there and they'll go back to where they're supposed to be. Does anybody have any questions about the 9 factors in relapse or the types of relapse? Yes.
Just a couple things. When you're doing the IPR, how do you prevent using black triangles? If they've got really...
If they've got flat contacts already?
Yeah.
Okay. I'm going to address that.
Okay.
Hold on a second. It means I have to get out of the slideshow.
Okay.
Can I address that at the end?
Yes.
Because I'll pull up the slide. Because really the IPR isn't done on everybody. It's basically done on patients that have a mesiodistal and buccolingual width discrepancy. There's an index that we use to determine which teeth might need to have that. We actually reduce the black triangles by making those contacts less triangular, right, and making them more broad. But I'm going to pull up the slide at the end. Anybody else have any questions about the yes?
And I'm assuming you're talking about complete permanent dentition. Does all this apply to mixed dentition as well?
Actually, the mixed dentition is a little different. That's actually a really good conversation for another lunch and learn, because there's a lot of advances in quote-unquote early treatment. I know that there's people are trying to get away from expanders by doing expanded arch wires, and I mean, the jury's out on that because you're not getting sutural expansion, you're getting to make the teeth. But for retention at the end of phase 1, I almost always put the patient in a nighttime retainer. It's a Holly retainer that I can trim and guide the new teeth that are growing in. So they're not wearing it all the time, they're popping it in at nighttime to maintain the arch length while the permanent teeth are coming in. Because we've got so much going on with the dentition that I can't just, go away and, you know, if the baby teeth are coming out early or too late. So yeah, during that interim phase, I do put them in the retainer.
For the bonded retainers, the stiff wire that goes just on the fleas versus integrated that's more from every tooth. Is there any difference in the result with that, since the stiff wire is a little more hygienic?
It depends on the bracket technology, whether or not you've done the type of rotations, and so if you've got a severely crowded case, lots of rotations, you're going to want to bond to each individual tooth if you haven't overcorrected or done a fibrotomy. Because if you just bond to the canine teeth, the front teeth can still rotate. They may not, you know, totally come out, but they can still rotate down there. I presently use, when I do a bond and retainer, I bond to each tooth. I know. Anybody else? Yeah, it depends if it's a tooth size discrepancy or if it's elastic fibers. Because if you're getting the rotation, if you have the teeth lined up and they're just rotating because you've either expanded it or canine descends and those teeth want to go back, or their teeth are rotated and the crestal fibers are pulling them back. There's all these different variables. Okay, so currently my retention goals are to change the amount of relapse associated with orthodontic tooth movement by neutralizing those 9 local factors. So taking care of the issues that I know are going to lead to immediate orthodontic relapse. And I want to move as many of my patients into the fast track of orthodontic relapse. Sounds great, right? My retention dream is limited or no retainers. That would be if I could wave the magic wand, that's what I want. However, there are challenges. So I find that my number 1 challenge is either at the beginning of treatment or at the end of treatment. So at the beginning of treatment, and I have a new patient in my office, and I'm telling them they need to have extractions, and they've been somewhere else, and they told them they didn't have to do extraction. That's an issue. Well, can't you just do it non-extraction? Well, yes, but these are the consequences. Oh, well, I don't mind, little Susie, she can't handle extraction. We don't want extraction. Oh, little Susie can't handle a fibrotomy, she won't do it. We can't do it. And that's too invasive. No IPR, you're going to take away enamel, they're going to get cavities all over the place. It's terrible. Why would you even think that? Patients that are like, oh, Courtney's got graduation, she needs her braces off. I know you said 2 years, but we really want them off now, and it's 6 months early, and they look pretty good. Patients who don't wear rubber bands, don't keep their teeth clean, refuse the restorative requirements, because I talked to them at the beginning. If they have these thick anterior crowns, I highly recommend they're going to need to have them done at the end. We've totally forgotten that we discussed this. They have habits with bone biology, root molars. I mean, the list goes on. There's a ton of stuff on the patient. There's a patient role. There's also the dentist, orthodontist role. So early debond. If somebody says, I really want to take these braces off, was my decision to say, okay, we'll take them on. I haven't really finished her. It's not really stable. But I really like them, and she's got graduation, and she's got prom. Oh, I will. We've got poor oral hygiene that wasn't addressed throughout treatment. Poor diagnosis. I didn't, maybe I didn't diagnose something right. I didn't spend enough time with the case, and I didn't look at those overcorrections. That never happens to me. I'm awesome. Inadequate communication of treatment goals, so explaining to the patient early on, you're a borderline extraction case. We don't have to take out teeth, but you're going to have retainers for the rest of your life. Inadequate plan for growth. So maybe they grow averse to what our treatments are. And lastly, I have to say, when I was in school, we saw like 5 patients a day. When you get out of school and you got your own business, you're supposed to see 75 to 100 patients a day to be a clinically efficient orthodontist.
Wow.
Wow. I don't see that many patients. I can't handle it.
No.
But it's all about efficiency. It's all about being able to see as many patients as you can, get them in, get them out, get moving on with your life. And they started back in the day with bands and brackets. So back in the 70s, 80s, they switched over from having bands around all the teeth and gluing the braces on. So instead of having an orthodontic bonding appointment that was 3.5 hours long to fit bands on all the teeth, you put them on in an hour and they bonded to the teeth. That's great. And then we had these braces that were all pre-adjusted, that if you put a square wire in and they get all straight, perfect. Very efficient. Because you don't have to do all those little bends. And then don't forget the super elastic wires that move the teeth really quickly. Those are great too. And you know what? Now they can make them all different widths and sizes. But it's really not efficient to have 50 different wire sizes in your office. You really only need to have one, the biggest. All of the preformed arch wires that are being presented now, I printed out from my bracket company. Their arch wire template. There is one arch wire template that doesn't expand payments. 92% of their patients buy the biggest, or of their clients buy the biggest arch wires. Preformed arch wires will expand canine width. If you're going to use them, you need to let the patient know that we're going to be expanding that canine width, the stability is going to go down, and you're going to have a bonded retainer. The Damon or other biodimensional non-extraction treatment, they're dependent upon using wires and mechanics that result in expanded arch width, altering the lower arch form, expanding intercanine width, anteriorly displacing the incisors by tipping them forward. And they actually don't have wires that fill the entire slot on those braces, so there's no way to get adequate torque on your teeth. Your finishing is very, very challenging. I use these. I use Damon. I don't have a problem with it, but I use it wisely. We used to do, I would say, probably 80, I jumped on the bandwagon. I drank the Kool-Aid. I was like, hey, I want to do that. I only want to see my patients every 8 weeks. I want to see 100 patients a day. Sure, why not? That sounds great. I just have to throw those wires in, those special braces, and everything's great. Nobody ever has to have it extracted. Awesome. I'm totally for it. I drank the Kool-Aid, and about a year and a half later, my finishes were I still see those patients and I'm like, oh! They're all in bonded retainers. They're all in lifetime retention. It's frustrating. These can be used. They have to be used judiciously. I would say maybe 50%, if that, of my patients are in a Damon bracket. And it's not on these patients that we're blowing out the incisors. The most important thing that I got out of this when I was doing my research was this Damon split retainer is based on the soft tissue. They know that we're doing that. We're pushing everything out to the cheeks. We're expanding everything. If they don't retain it with this length, your patients are going to lose their correction. So this patient came to me. Can you guys see this okay? So this is a 28-year-old female. She actually came in yesterday, and I was like, I'm preparing my lecture. She came to me from another orthodontist for a 5th opinion. Number 5. She had 2 orthodontists that said extractions, and 2 orthodontists that said she didn't need any extractions at all. She just needed this bottom arch leveled out and rubber bands to help bring the lower jaw forward. I don't know if you guys can appreciate this right here. This tooth right here is totally out on the buccal bone. If we were to do a CAT scan, I'd be really surprised there wasn't a huge bony dehiscence down here. These teeth are tipped so far forward, and 2 orthodontists told her we can do this non-extraction. This woman would have 4 teeth sticking out there. This is just tragic. And I told her, I said, you gotta do extraction. Sorry. She's like, thankfully, I explained to her my philosophy, and if we do it, you can do it, but you're stuck. You're probably gonna be doing bone grafts and gum grafts and all the rest. She's 28, she's a young lady. This was sad. This was really sad for me to see. So my conclusions are, again, we're going to change the rate of relapse associated with tooth movement by neutralizing those 9 local factors. So if you hear from one of your patients that I'm telling them they need to have a fibrotomy or they need to have IPR or extraction, it's because this is what we've done. We've gone through what's going to be really helpful to that patient. And I want to move as many patients as I can from that initial orthodontic relapse to that physiological aging relapse. I'd like to imagine a time when there's no relapse. That's kind of my goal. I might be a dreamer, but that's what I say. Does anybody have any questions about from today? No? Okay. Well, that's it. If anybody has any questions, let me know. We've had this all on videotape. So we have a YouTube channel you can go to. You can also get a disc directly from my PRC, Katrin, or Trish can get one for you too. If you want copies of the slides for any reason, we have those as well too. So thank you again for coming. I hope everything was yummy. And we're well on time, so everybody gets to go back to work.